Very good evening to all of you. The topic assigned to me for the talk this evening is the use of ultrasound guidance for PCNL for reducing radiation exposure in PCNL excess. I wish all of you good health in this troubled time, and I hope you are all safe and home. And this is a very useful and productive educational activity which our group is taking, and I hope you are all there at homes to participate in this program. And I believe there was a very useful discussion during the day on laparoscopy. So I'm going to talk about the usefulness of ultrasound in PCNL access and how it can help the regular conventional approach using fluoroscopic guidance. Now we all understand that PCNL is the most efficient way of taking care of upper tract urolithiasis, especially the moderate and large volume stone disease, because of its highest efficiency in achieving stone-free rates and achieving complete clearance. On the other hand, as opposed to other modalities, PCNL also has relatively higher morbidity, we all understand. And in these past few years, steady attempts have been made to reduce the morbidity of PCNL so that we can achieve good results at low morbidity. And this procedure can match and maybe replace other options for management of stone disease. Why is PCNL a challenge even after 40 years of its inception? It was in 1980 or a little earlier than that PCNL came into existence, and even today a lot of us continue to find it difficult to come to terms with the morbidity of PCNL, and the reason is the difficulty in achieving excess. And the reason why puncture in PCNL is difficult is something akin to this famous story from Mahabharata. And those of you who are in India or from India will, of course, know this story, how the famous hero Arjun was able to uh, target the fish eye on a rotating wheel, looking at its reflection in the water below. So puncture in PCNL is something like this. You are looking somewhere else and you are hitting the target somewhere else on a two-dimensional projection. And that is the reason why PCNL puncture is so challenging. And what we are trying to achieve is getting to the pelvic calyceal system through the shortest route in a straight line to achieve our target, that is reaching the stone and making clearance or complete clearance. And this task is challenging because kidney is such a vascular organ, and the vascular supply of the kidney is so closely intertwined with the pelvic calyceal system. And this anatomy is difficult to understand, and this is the biggest challenge which we face when we are making a puncture into the pelvic calyceal system. And the objective here is to get to the pelvic calyceal system without disturbing the vessels or without injuring the vessels. And how we can achieve this is by, first of all, trying to go into the posterior calyx as far as possible, because that is the area where the vascular supply of the anterior division of the renal artery and the posterior division of the renal artery meet, and this is the least vascular part of the kidney, the so-called Brodell's line. So as long as you are able to identify this region this region, and you can target the posterior calyx as far as possible, you are relatively safe. Another very important thing which was brought out by a series of studies by this gentleman, Sampio, published around the turn of the century, was that if you can make your puncture through the papilla, then you will avoid all the important major vessels, the interlobar vessels, and your puncture will be accurate and without bleeding. However, if you don't identify the papilla, and if you go in the intrapapillary region or you make your entry through the infundibulum, then you will injure the intrapapillary or interlobar vessels and bleeding will happen. Now, it is amazing that we were doing PCNL for almost 15-20 years without recognizing this simple fact, and we caused so much bleeding before that. And ever since this fact dawned upon us, it has made a huge difference to our outcomes, and bleeding has now, we have for the first time been able to understand why there used to be bleeding in PCNL and how we can achieve relatively bloodless PCNL now. Now, conventionally, we have been doing all our punctures, at least in this country, using fluoroscopic guided puncture, either using the bullseye technique or using any of the variations of the freehand technique, which is being called triangulation or whatever, or a combination of these two. And every one of us has his own way of doing it and his own way of calling it. However, you all will agree that fluoroscopic guided puncture has its own challenges, and it is not always possible to identify the posterior calyx, especially in patients with complicated pelvic ileal anatomy, in staghorn stones, and many times it is simply a matter of guesswork how you are entering the pelvic ileal system. And as soon as you enter and you get water, you are just happy that you are in. If you add one more modality, and the reason why fluoroscopy is a problem is because, as I earlier said, it is a two-dimensional picture that you see on the fluoroscreen, whereas you are hitting a three-dimensional object, and the depth perception is missing on fluoroscopy, which is only partly taken care of by using a C-arm image intensifier and looking at the image in two different planes. However, if you start using ultrasound, you will realize very quickly that ultrasound gives you a real-time three-dimensional picture of the kidney, and you can see again in real time the kidney position of the kidney, the movement of the kidney with respiration, the position of the post. You can differentiate between the posterior and anterior calyx. You can see the adjacent structures. You can identify the spleen, the kidney, the liver. You can see where the pleura and the diaphragm is, and it makes things so much simpler. And you can identify a hydronephrotic kidney, the fluid, so easily. And if not, you can inject fluid through the ureteric catheter. You can give a diuretic to distend the pelvic ileal system to make your identification easy. And we must all give credit to and thank Dr. Mahesh Desai, who, among so many other things that he has taught to all of us, he was the first person to identify and promote the use of ultrasound in PCNL puncture way back in the year 2000. And then several of his subsequent publications, he has shown, demonstrated, and taught to us how you can use ultrasound for the benefit of making accurate puncture. And now I must tell you that large part of the world, many countries, people are using ultrasound as the first choice for making puncture in PCNL. And Dr. Desai had in his initial publications repeatedly stressed that it reduces radiation exposure, avoids visceral injury, and also intrarenal vascular injury, and gives you the shortest and most straight access to the pelvic ileal system, and reduces morbidity especially in pediatric population, special situations, abnormally placed kidneys, ectopic kidneys, horseshoe kidneys, and in supine PCNL, we have found all this to be true and very, very useful when you start using ultrasound. Now, I can tell you from my own experience, for the first 10 or 15 years, I was using only fluoro-guided punctures. And ever since that time, for the last 15-20 years, I've been using uh, uh, both combination of ultrasound and fluoroscopy. And I can tell you that it makes a world of difference if you have an added support in ultrasound guided puncture. So what ultrasound does is, as I said earlier, I would like to, it is worth repeating that it gives you a real time assessment of the location of the kidney, its angle, its the plane and depth of puncture. It gives you the third dimension, the depth which is missing on fluoroscopy. You can identify the posterior calyx from anterior calyx. You can uh, identify the adjacent structures. And most importantly, it reduces the radiation exposure exponentially. In the beginning, the difference was less, but with experience, we have found that the amount of radiation exposure has drastically reduced. And this is the experience of almost everybody who's been using ultrasound for guidance. Now, if you are using ultrasound for puncture guidance, there are a few things which must be understood. First thing is that every ultrasound machine and every ultrasound transducer has uh, the possibility of using a probe guide. Now you can use a freehand ultrasound guided puncture as well, but if you use a probe guide, then your puncture becomes more accurate. So a guide is a very valuable addition. Now the guides are normally not purchased when you purchase the ultrasound, but you can always order it afterwards. And almost every machine has the guide available. The important thing is that the regular ultrasound probe that we use for the abdomen has a very wide face, and then the probe, the guide is too far from the center of the transducer, and it may not be very useful for guided puncture. So if you have a small size convex transducer, then it becomes easier to use. So some of the older machines and some of the newer machines which have specific, just like the B&K machine, the ultrasound machine from B&K has a special convex transducer with a small footprint, as they call it, which allows you a more accurate, and the puncture guide give you the site of puncture which is closer to the center of the transducer, which helps especially when you are making supracostal punctures, because the space available there is very small. The second thing is, so the puncture guide is a great asset. Although I am aware that a lot of people, especially the radiologists, become expert in freehand punctures also, ultrasound guided freehand punctures. But if you have a small target, then it becomes difficult using a freehand puncture. Another interesting addition which has happened in the recent years is that some of the manufacturers, especially Cook, have now come out with eco-tip needles. Now these needles have very fine serrations near the tip, and they will reflect better on ultrasound. And thus, when you are doing ultrasound guided puncture, then these needles show up better when you are using ultrasound, and they help a great deal. And we've been using these eco-tip needles for last many years with great benefit. So how you do this is, you have now we have this, one of our machines has this old mechanical transducer, but it works very well because it has a small face, and you have a puncture guide which fits very well. So what you do is you cover it with a sterile cover, and you have a puncture guide attached to it, and then through the puncture guide you can pass the needle, and there is a marker on the screen, a line visible on the screen. So when you pass the needle passes along the marker visible on the screen, and then it becomes very simple and easy for you to identify and make your puncture. So I'll just show you a short video to demonstrate how it works. Um, on the ultrasound screen, you have these two marker lines, and the needle passes between this space. Now there can be a little bit of deviation of the needle because of the resistance of the tissue. So it is not entirely 100% accurate in the same line. Sometimes there can be a little bit of deviation. So one has to be a little careful. But you can see the dilated pelvic system. You can see the needle um, uh, uh, going in. You may require a little small incision on the skin, and then you can start passing the needle. And even in an undilated pelvic, and you can see the needle going in, and even in an undilated pelvic system, and you can see the water coming without even in most of the time you can see this happen in one go, just one single pass, and you are in without any radiation. The only another case where there is hardly any dilatation, and you can see the needle going into the targeted calyx without on ultrasound, pure ultrasound guidance. Now once your needle is in and you draw water, that is when you use the fluoroscopy for the first time. And then you inject a little bit of contrast through the ureteric catheter, occasionally through the needle, to confirm the location, and then you pass the guide wire. And mind you, the entire operation cannot be easily done with ultrasound, although some Chinese people claim that they do this. Most of us will switch to fluoro after this point and pass the guide wire under fluoroscopic guidance, and then the dilatation is done under fluoroscopic guidance. So when we say ultrasound guided PCNL, it is always ultrasound and fluoro guided, except, as I said, some of our Chinese colleagues who claim to do completely fluoro-free PCNL. There are publications claiming completely fluoro-free PCNL even for staghorn stones, and claiming complete clearance. Now, I have my own doubts, but yes, there are people who do this, and I'm sure they must have developed adequate expertise. But if you ask me, I would be happier doing my puncture with ultrasound and then using just spot fluoroscopy for subsequent passage of wire and dilatation. And we do in many of our mini perks one-step dilatation. So the actual radiation exposure many times in the entire procedure of making puncture, passing wire, dilatation, and placing the implant sheath is less than 10 seconds in most of our mini PCNLs. Now, some years ago, it's almost 10 years now, we published our results of that time. Our experience was relatively new. We'd been doing ultrasound guided punctures for about 8 to 10 years at that time. And we published our results of this study which we conducted, and we could show that the use of ultrasound reduced the time required for puncture and tract formation, and most importantly, it reduced the radiation exposure significantly in making the puncture and subsequent tract dilatation. In addition, the accuracy of puncture also improved, and the number of passes required for making puncture was also significantly reduced with the use of ultrasound. Since then, actually the results have improved even further. Another very interesting thing which we observed and we published actually was that if you can even use air as a contrast on ultrasound. If you use very small amount of air, then not only it shows up on fluoroscopy, but it also shows up on ultrasound. And you can actually see air rising up into the posterior calyx on ultrasound, and you can very nicely identify a posterior calyx because the air rises up and you can see the posterior calyx on ultrasound, and you can make a puncture targeting the posterior calyx because air on ultrasound looks like the stone. Looks like white, opaque. Dr. Desai made many publications on ultrasound guided punctures, and this was one which demonstrated the usefulness of puncture guide. Many other people have published on ultrasound guided puncture, and this is one publication in relatively recent years, and they have also confirmed that the interesting study thing about this study is that they have evaluated the learning curve, and what they have shown is that after 20 cases one can be an expert in doing ultrasound guided punctures. And another interesting thing that they have shown is that the total fluoroscopic screening time has reduced significantly from, as you can see here, from 150 seconds to 33 seconds using ultrasound, and radiation exposure from 47 milligray to 7 milligray. So there is a almost drop to 20% by use of ultrasound. And there is a study from Britain which shows the drop to almost 10% if you start using ultrasound. And there have been many publications in the recent years which have attested to the safety and efficacy of use of ultrasound for punctures in PCNL. So I will just quote the last line of our discussion in our publication, that to follow the principle of ALARA, that is to achieve low radiation, which is very important in high volume centers. We are doing multiple PCNLs and especially large stones, and there are so many centers in this country. Ultrasound guided puncture contributes significantly to reduction in radiation exposure and improvement in accuracy and safety of PCNL. And since in our country it is us urologists who are making these punctures, it is very, very important for more and more of us to learn to do ultrasound guided punctures through training and orientation programs. There are, I understand, problems relating to legislation in this country, but I'm sure there are ways that they can be taken care of. Well, thank you very much.